sessione. Invito i relatori della terza sessione e i moderatori a venire. Jorge Corona. Jorgito. Sì.
Ma che fa? Fino alla fine, poi lo lasciamo così.
Andrew Lee.
Fino ai 5, lasciamo fino ai 5.
Andrew Lee e Jorge Corona. Giusto un minuto che aspettiamo gli ultimi e incominciamo. Grazie.
Okay, could I have the slides up? So I hope you had a good lunch, and we're going to be talking about trauma. As a neuro-ophthalmologist, your job is to swing that flashlight and identify if it's traumatic optic neuropathy, make sure there's no open globe or other retinal damage that needs surgery. But if it is a traumatic optic neuropathy, there's still no proven effective therapy. The disclosures are the same, have nothing to do with this. This S on Superman's chest is not an S. He came to this planet with that outfit. It is the Kryptonian symbol for hope. So it's not an S, it's Kryptonian for hope. Your job is to give hope. It is your superpower. Traumatic optic neuropathy is a clinical diagnosis. There's nothing to see. The doctor sees nothing, the patient sees nothing. There's nothing to see. The only thing that you have is swinging that light and detecting that RAPD. Of course, the first thing you're going to do is evaluate and treat any life-threatening or globe-threatening injuries first. There are some surgical indications, and I will show them to you, but there's no evidence base for them. And you must consider the risk-benefit ratio of steroids. There have been several studies, but not for traumatic optic neuropathy, for spinal cord and for head injury. The one trial that was done for the International Optic Nerve Trauma Study was inconclusive. So there's no clear evidence-based recommendation for steroids, either the dose, the duration, the route, and therefore no standard of care has been established for corticosteroids for traumatic optic neuropathy. If you look at the types of injuries that we see with traumatic optic neuropathy, it's often a blow to the forehead right here. And that's because the impact is transmitted to the canal. So the orbit is like an ice cream cone, and it directs the force wave on holographic imaging right down onto the canal. And so that's why there's nothing really to see. It's an indirect traumatic optic neuropathy. The one indication that I think you should consider is sheath hematoma or canal fracture. For those cases, we do let our surgeons talk to the patients. Of course, there hasn't been a good randomized trial for this, but I think if a piece of bone is sticking in your optic nerve, you might consider taking the bone out. The other is this sheath hematoma. So normally we do CAT scans because we're looking at trauma cases and for fracture, but we will do a MRI if we think there's a sheath hematoma, because a sheath hematoma could undergo a sheath decompression, much like we do for sheath decompressions for papilledema. And so those are the two things I would say from a neuro-op standpoint on the imaging. Of course, if the nerve is pulled off the back of the eye, you can't do anything about that. So it looks like this. There's like a hole in the eye. It can be either partial or complete, and the hemorrhage just spews out from around the nerve. So it's this peripapillary, Mount Vesuvius of blood coming out. That is not going to be amenable to any treatment. So, of course, there's a big hole in the eye. It can cause a central retinal artery occlusion because you plucked off the central retinal artery, and it causes this retinal whitening. So any of these are going to be very bad prognostic features. You definitely should document these. So in terms of treatment, is there a treatment from a neuro-ophthalmic standpoint for traumatic optic neuropathy? I'll give you the short answer first, no. But the long answer is yes, no, maybe. There's some individualized caveats here. So I'm going to show you what we have, and then you can decide for yourself. So there are grades of evidence, not just for traumatic optic neuropathy, but for any kind of question like this, is there a treatment? Level 1 evidence, meta-analysis from a randomized controlled clinical trial, or at least one randomized controlled trial. We do not have this kind of level 1 evidence for traumatic optic neuropathy. Level 2 is evidence from at least one controlled study with or without randomization and one quasi-experimental design. We do have this for the International Optic Nerve Trauma Study, but it was inconclusive. Level 3 is experimental evidence from either case control studies or case series. We have a lot of those, but they're all conflicting. And level 4 is expert opinion. A guy like me stands up here and says, do it or don't do it. Those levels translate into grades of evidence. So grade 1 is corresponding to the randomized controlled clinical trial, B, category 2 evidence, C, and D, etc. So the evidence that we have for traumatic optic neuropathy is extrapolated B, mostly C, and a lot of D. So this is what it means to you in the real world. A level 1 evidence, grade A, is a must-do. Standard of care, highly recommended practice. There is no standard of care recommendation based on level 1 evidence for traumatic optic neuropathy. There is no must-do. Number 2 is should-do. Should-do means you should do it or show just cause why you're not doing it. We do not have level 2 evidence for traumatic optic neuropathy. There's no should-do. But there is could-do. Could-do is a practice option. You can do it. You could not do it. You have to individualize case by case. And then there's voodoo. There's a lot of voodoo treatments for traumatic optic neuropathy. None of them have been proven to be effective. And some of them are so new, might not be true. And then there's doo-doo. Doo-doo is unsupported, might be false, and there's evidence to suggest harm. So a lot of the studies are either voodoo, and some of them are doo-doo, which means it harms people. So if you look at the International Optic Nerve Trauma Study, IONTS, the main conclusion of that study is there's no standard of care. Surgery is unproven and may or may not be beneficial. The dose, duration, and route of corticosteroid could not be established by this very large, prospective, international, multi-center trial. And so, based on the data that we have, there is no evidence-based recommendation that can be made for steroids and traumatic optic neuropathy. The data we have from the clinical trial is extrapolated from the National Acute Spinal Cord Injury Study, NASCUS. In NASCUS, spinal cord injury, but not traumatic optic neuropathy, patients were given intravenous methylprednisolone at a dose of 30 mg per kg. In the original study, it was 5.4 mg per kg per hour for 24 to 48 hours. And in that study, if you were treated within 8 hours of spinal cord injury, your motor outcome was better. But if you were given the steroid after 8 hours, you did worse in the post hoc analysis. So this data is not only extrapolated from spinal cord, it shows that we have a very narrow window for neuroprotection given high-dose steroids, and so it's not clear from this study what we're supposed to be doing. Nevertheless, many people extrapolated from this study and said give high-dose intravenous methylprednisolone. So I'm going to show you a summary of 16 major studies, 715 sample size patients. All of them are variable with weak designs, retrospective, small sample sizes. They have no control arm, non-standardized visual outcomes, and variable treatment regimens of dose, duration, and route of steroid. So here's kind of what it looks like in a single table. And you can already notice that if you have a table that has 0% and 65% and 72%, you know something's not right with this data. It's just all over the place. So these numbers from the treated patients who improved, every single number is on this chart. And if you don't treat the person, it's the same kind of scattergram. So you got studies that show nobody got better if you didn't get steroids. You got people who said 67% of 24 people in the Malaysia study got better and got zero treatment. So both untreated patients and treated patients have improvement, and both treated patients and untreated patients have no improvement. So what conclusion can you draw from this data? This data sucks. That's the conclusion. If you look at the doses that were used in these 16 studies, they had low dose, moderate dose, high dose, very high dose, mega dose, industrial strength dose. They had like every single dose known to man, and it didn't seem to make any difference in the analysis. You should know, however, there's a risk-benefit decision you have to make based on, again, extrapolation from another study. That study was called the Corticosteroid Randomization After Significant Head Injury, the CRASH study. In the CRASH study, which was a multi-center randomized controlled study, but not of traumatic optic neuropathy, it was for head injury, this study had to be terminated because more people died in the steroid arm. So steroids are currently not recommended for head injury based on CRASH. It's not clear where the mortality came from, but it's thought to be increased risk of infection, both sepsis and pneumonia in NASCUS 3, but also hyperglycemia was a risk factor in the other two NASCUS trials. So, in summary, what you should be taking away from traumatic optic neuropathy is, from a neuro-op standpoint, we have no standard of care recommendation for you. You should consider the risk and benefits of steroids, even though there's no clear level 1 evidence. It is a could do. The dose, the duration, the route are not defined and therefore a practice option. And I think it means do what you think is best for an individual case. The CRASH study, the corticosteroid randomization after significant head injury, showed you were more likely to die if you received the corticosteroids, and therefore we in Houston do not give corticosteroids for traumatic optic neuropathy if your Glasgow Coma scale is worse than 14. Because no one dies from untreated traumatic optic neuropathy, but people definitely died in the CRASH study. You need to know a little bit about this voodoo thing called erythropoietin. In the traumatic optic neuropathy treatment trial 2, which evaluated the efficacy of different doses of erythropoietin in a multi-center randomized double-blind trial, it showed meh. It did not establish it as a standard of care option. However, it's something you should know about. It did not prove to be efficacious. It's been studied now in all sorts of different things, and none of it works. So the take-home summary, steroids in traumatic optic neuropathy, yes, no, maybe. There's no clear, definite evidence for any of these routes, dose or durations. And I think you just have to do what you think is best on an individual case-by-case basis. We in Houston personally will do a sheath decompression if we see a sheath hematoma, and we will consider surgical removal of bone fragment if it's a canal fracture or it's poking them in the optic nerve. Bottom line is, your superpower is giving hope. And Kryptonian, that's this S. And I thank you for your time and attention.
Dr. DeMartellari. And sorry, but I have a service communication. If you have any question, you can write it down in the app of the ICOS. And it's really simple. You just tap on your iPhone and write it down what you want to ask in the question session. Okay, thank you.
Good afternoon. I'm honored to be speaking with you. I want to extend my thanks to Luigi and my mentor, Rita. I entitled this talk Conversations. There are conversations I wish I had had and conversations that we did have. I deployed as part of the 286 Eye Surgical Team in support of Operation Iraqi Freedom at the very beginning of the war in March of 2003. I have no financial disclosures. These are my views and my views only. I want to dedicate this to Dr. Tony Johnson. This was the team that I was part of. My predecessors felt that our skill set would be best functional as a complete team. So we had 3 ophthalmologists, a OR scrub tech, an ophthalmic technician, a OR circulating nurse, and a nurse anesthetist. Now, was this the right decision? I don't know. Would we have been better off as a solo ophthalmologist? I was a comprehensive ophthalmologist at the time prior to my ACE Operas fellowship. Dr. Bladen was an oculoplastic surgeon. Tony was a cornea refractive surgeon. Was this the right mix, the right makeup? I don't know. We just happened to be the people who got lucky to be called up. We felt it was important that we travel with our equipment, that we be as light and flexible as possible. Here you see us all crated up and palletized, ready to roll. And yes, we were off finally, day one of the war. We landed when the Scud missile sirens were going off, and everyone hurried to find a modern day bunker and don a gas mask. You see several of us sitting on our carry-on backpacks. Now my backpack unfortunately had my surgical loops in it, my favorite suture, and not my gas mask. Not the smartest maneuver I ever made. Mine was in my duffel bag, which was still in the cargo hold of the plane. That night, the first wave of casualties arrived. Everything still happens in the middle of the night. And here you see that triage ongoing. And after the night ended, yes, we finally found our chem suits, got ourselves back into the bunker, back and forth, and Tony woke up and we discovered we were in the morgue. And then Diane Sawyer arrived, so it's time for the tour. We were attached to the 47th Combat Support Hospital. You see a little edge of the flight line down at the bottom. Patients arrived by Black Hawk helicopter. You see two long rows of tented. We had 4 ORs. And the hospital could be divided and leapfrogged ahead in parts, in modules, to keep a pace with the advancement of the war. At the very top of the screen, you see locally purchased Bedouin tents. Those were our bed tents. So this was an important conversation that should have been had, is like, what are those made out of, and are they highly flammable? At the time, yes, highly, highly flammable. This was our little makeshift eye clinic we set up. You see a gorgeous hawk stripe, which we loved. I put this slide up here so that you can see this kind of reclining paint shape. We had a CT scanner. We were excited. Other conversations that needed to take place was the heat, the dust, the maintenance of this equipment. Be prepared. We loved our technology. I show you this slide because you see some like drapage up at the top too on the your right side in the center. The generators automatically shut off at 120 degrees, right when you wanted them the most. So we started to improvise, give them some shade. And this is what the inside of one of the corridors in the hospital looked like. You see the water on the floor. We were forever combating dust. Here's one of our wards, lots of AC pouring out of that plenum up above, and people would volunteer to work. Only time I ever saw people volunteering nonstop to work. We were prepared for nuclear, biological, and chemical warfare. It terrified everybody. The hospital came with instructions about how to bubble up. Some of us were assigned to be inside the bubble, some not so lucky. We were ready for decontamination procedures. Some people trusted the system, some didn't. Have you ever operated in a gas mask? I hadn't. Here you see our neurosurgeons busy at work. Our ORs were designed to have 2 tables running simultaneously. The conversation that happened here was the hospital planner said no, no, and no. Will you set up your big, beautiful microscope that you want to use? Because neurosurgery wants their microscope, everybody else wants their precious equipment, and no. So luckily we had a small portable humanitarian-style microscope. It arrived the day before we left, so we hadn't put it together. We also hadn't put together our OR stools. They were antique, and it didn't go high enough for me, and people got creative and built me a pedestal so I didn't have to stand all day long. We eventually got to set up our Leica microscope that we had back home. We found our rhythm. We had a portable slit lamp. It was not uncommon for us to get called to the OR for the first eye exam, so the vast majority of our patients didn't have a pre-op vision. They were there for other life-saving measures. Another conversation that was important was, how are you going to communicate with the next level of care? In 2003, we didn't have an internet there. We didn't have electronic health records. This was one creative outside of the box thinking that happened. We had Kevlar to protect lots of us, but our mid-face was very exposed. This is an entrance wound in the forehead and an exit wound in my orbit. I became very well adversed in diagnosing a CSF leak in my orbit. I was super blessed to get to work with a neurosurgical team. Our eye team eventually was split up, and I did get assigned to a head and neck team, so this was a skill set that I loved gaining prior to my fellowship. Although we tell you usually in trauma that all the tissue's there, occasionally it isn't. So here you see a full thickness skin graft and what was left of his eye. Now, we didn't remove very many eyes. We did our best to close everything. Everyone needed to know that they had the best care possible when they went home to try to save their vision. The next wave of patients, civilians caught in the crossfire, including children. So here's the conversation we hadn't had with our colleagues, like, does anesthesia have a pediatric ET tube? They didn't. Time to get creative. Our next conversation was, okay, we repaired that globe, and one, I don't know how to speak with this child. Two, I don't have parents. I don't know our culture. What's going to happen? We were all worried about sympathetic ophthalmia. So this was our decision. Was it the right decision? Will she be accepted back into her culture with just one eye? Is she ever going to get an ocular prosthesis? What is left of care in her country? It wasn't uncommon for us to see CT images prior to seeing the patient just because of where our little clinic was located. Clearly this left eye is not doing well, but when you look at the right side, you're like, wow, is this our first case of undiagnosed sympathetic ophthalmia? This eye is a good 10 to 14 days old, and that's what that removal looked like. Our next wave were children picking up bright, shiny things. This was an unexploded ordnance that went off, demolishing his face, his right hand, and what I don't tell you is he lost both of his feet. And that was the large fragment that was in his brain. That's what was left of his orbit. I show you this so that the students and residents know that if you're going to do this kind of subtotal exoneration closure, you need to remove all the glandular mucus secreting tissues, all the conjunctiva that you can find needs to go, the meibomian glands need to go, so that you don't end up with a mucopioceal. And this was the fragment that was removed from his brain. More gunpowder blast residue. This was someone who was planting an IED that inadvertently went off, and he sustained bilateral eye injuries. Now, you get to recognize these IED injuries just because they're just dirty, mucky, gunky, messy. And bilateral injuries were not uncommon, and it was not uncommon for one eye to have more than one rupture site. This was the closure for this eye. Once it was all debrided of all the dirt and gunk, the cornea was just mush, and so conjunctival flap was pulled down, kind of like you would do for a trab. The other eye, that's what it was looked like once it was debrided. Unfortunately, this patient was bilaterally blind. Serial washouts were done to improve his gunpowder tattooing, and this was his final look. Other conversations that were really important. Our pilots were concerned with intraocular air and altitude. We weren't so concerned. Little tiny bubbles weren't of big rush, but nearly 100% of our soldiers' patients, I never saw post-op day one. They were flown out before 24 hours were out. And so that was another important conversation to have with your colleagues back home is, what can we do to improve? What did we do wrong? What can we do better? Orbital fracture repair. Now, we didn't deploy with any plates or screws, and I did one fracture repair in country. It was a water bottle that got tossed at somebody, and it caused a blow-up fracture, and we had that patient in the OR within an hour, and it was a dream case. I know we talk about waiting 2 weeks, 6 weeks to 8 weeks, but wow, no edema, nothing stuck down. It was the funnest fracture case I have ever done. More importantly, though, orbital compartment syndrome, conversation you need to have with your medics and frontline people. There's that golden hour of when you can really impact someone's vision by doing a canthotomy, cantholysis, and training those people up front to recognize it and take care of it was important. A few words about combined blast and burn patients, because this was not uncommon. Orbital compartment syndrome is a real thing for them with that aggressive fluid resuscitation. We had a burn team that flew out to get these patients and fly them back home and resuscitate them in air. So you needed to think ahead of time. Are they going to need a canthotomy, cantholysis? Patients with third-degree burns, that tissue is leather. It doesn't expand. It doesn't allow that swelling to happen. So you might prophylactically need to be doing a canthotomy, cantholysis. Be wary of what is in the air. This flag was flowing for less than 30 days. That air is filled with toxins. And the VA, the Veterans Administration back in the United States has now recognized more than 20 cancers caused by what we were exposed to from burn pits and other things in the air. So take a moment, take a deep breath, be in awe of what's around you. Be aware of what you can't see and what you don't know. And lastly, my last conversation, and be happy to take this home. It's a very personal one to me, but Charles Bonnet syndrome is a real thing, and we really need to talk to our patients more about it. It is not just a, oh, by the way, you might notice this. It is real. And with that, I thank you for your time and attention.
Thank you, Sherry. Stunning presentation. And our next speaker, Stuart Seif, my hermano, and he's gonna talk about our experience in the war in Ukraine.
Well, thank you, Jorge, and I want to thank Luigi and Daniel for including me in this symposium. It's quite an honor to be here, and you know, it's actually kind of nice that I'm following Sherry, because you know, she said, well, she didn't know what happened when she put them on the airplane, and our experience in Ukraine has largely been what happens when you put them on the airplane, and what do we do next? And as great a job as let's see if we can get this to go. As great a job as we did in Iraqi freedom, etc., I've got to say the front line Ukrainian trauma surgeons are just amazing, and we have learned so much from their management of acute trauma. These are my disclosures, and I'm going to take a little bit of a twist on it as well. It's not just our experience in the Ukrainian war zone, but what happens to these injured soldiers and civilians, and how do we get them back into society? Aesthetics matter. So we all lived through the pandemic fairly recently, and during the pandemic, everybody was sitting in front of their computers looking at themselves, and we came up with a syndrome. It's called Zoom eyes, and you look at it and go, oh my God, is that me? And yeah, that's you. And so we had a huge surge of aesthetic surgery in the United States, and a lot of it revolved around eyes and noses. And it turns out that this kind of thing happens in any society that's undergoing emotional trauma and distress. And thus, we went through the period of Zoom eyes. And you can just look at this lady pre and post an endoscopic brow lift. Obviously, her post-op result, she's going to feel much better about herself after surgery than before, the next time she goes on a Zoom meeting. Well, a crisis came upon us once again. Sherry had one that she went through, and the world went through one on February 24th, 2022, when Russia invaded Ukraine. And many of us felt like we needed to do something. We couldn't just sit. And actually, one of Sherry's colleagues, Rob Mazzoli, is a good friend of mine. I got on the phone to Rob on a Sunday morning. He said, Rob, we got to do something. You did this telemedicine thing with people all around the world with U.S. troops getting telemedicine consults. We need to do something. Can we set that up for Ukraine? And then we realized, you know, people like Sherry with combat experience are pretty rare. We aren't going to know what to do. So we put together this consortium of people. We had 4 actually internet meetings. The program was sponsored by 3 international ophthalmic organizations. And obviously, a lot of people tuned in to these programs. And in Canada, the Canadian Ophthalmology Group created Eyes on Ukraine, which raised $1.5 million to send ophthalmic equipment and supplies to Ukraine. Well, ultimately, we were able to get in country, and facial plastic surgery went ahead of us, and there were 3 North American groups that went to Ukraine. Face the Future, the Canadian group, Face to Face, the Facial Plastics group, and Lead Global Surgical Missions out of Dallas. And they quickly realized they needed oculofacial plastic surgeons. They needed us. They couldn't do their work. And so Jorge somehow finagled his way into getting us invited to go with the LEAP team. And I guess we were kind of the second and third oculoplastics people in country. And Jorge and I have now been on 5 missions into Ukraine, and we've operated over 100 oculofacial cases. And these are the list of the American oculofacial plastic surgeons that have gone with the teams into Ukraine. The teams have tended to stay west. LEAP is the only team that has gone east into Kyiv. And our team was actually featured in the Washington Post about a year ago on New Year's Eve. In general, when we go, yeah, just like Sherry said, it's a focus on functional war injuries. That's what we went for. That's what we thought. And what we've come to learn is it's not just putting together the pieces. When they get to the next echelon of care, it's not just putting together the pieces. Now we have to integrate these individuals into society and make them look good. So let me, one of the things that happens a lot is these blast injuries seems to destroy the midface. And actually, Dr. DeMarley alluded to that. And as Mazzoli taught me, blast never forgets. It's like a cancer patient treated with radiation, and it never forgets, it never goes away. Ischemia is our worst enemy down the line. And these patients frequently lose their lower eyelid. And when you lose your lower eyelid, you lose the ability to retain a prosthesis and an artificial eye. This is a big deal. But yet we can't just bring flaps in because they'll die. My group with Laura Lee Smith had come up with this bucket handle bipedical flap that we were using in cancer patients. And the flap has vascular supply coming in from 2 sides, and so we could get them to survive. So we make an infraciliary incision about 4 to 5 millimeters long. It may not be ciliary. There's usually no eyelashes. There's no eyelid. You're going to make a new eyelid. And then you can put a medial suspension suture in place in the canthus. And we don't go necessarily full thickness, but we leave a little vascular layer on the bottom, and we fill the defect with a full thickness skin graft. And these usually work pretty well. This is an example on the patient you just saw. That's going to be the new eyelid margin. This is where we make the incision. And then here he is again, and here he is with the skin graft. And the reason the skin graft looks a little dusky is because they all go out and smoke the day after surgery. So, as my friends here from Ukraine know, it's Sife's rule. 1 cigarette a day, and these grafts pink up. And here he is with his prosthesis, not perfect, but much more socially acceptable. This is a case actually kind of similar to the one that Sherry showed. This is a bilateral, the blind patient. We actually saw this patient in Lviv, and it was quite similar. There was a shrapnel piece that went through the right orbit posteriorly across the optic nerve. Thank you, Andy Lee. There is nothing we're going to do about the vision in that eye, but the eye is there. There's the piece of shrapnel, and the piece of shrapnel was sitting in the left socket. And we removed the piece of shrapnel, but a lot of the troops in Ukraine believe that that there's going to be an artificial eye and they have to have the eye to make it work. And so they won't let us remove the ocular tissue. And we're all taught you need to get a good orbital implant in there to support a good ocular prosthesis. But guess what? In wartime, you can't go by all your conventional Western rules. You got to improvise. So we put a lot of ocular prostheses in between the lids just to get the people functional, like this gentleman. And he got blue eyes. Why? Because his sister wanted him to have blue eyes. And this is Nick. I can use his name because he's a public figure, and he talks about himself all the time. Before the war, he was a local politician. He was out of Kharkiv, and he was actually pro-Russian before the invasion, and he ended up on the front by his own account. And something happened to his car. Well, the world has seen his car upside down and blown up, and that's what happened to Nick. And he was very concerned, being a public figure, about his scars and no eye. So he underwent some full-thickness skin grafts and lipofilling. He can now wear a prosthesis, and his scars are significantly improved. And at Christmas time, this past year, he's now back in politics. He's on the city council of Kharkiv, and he's a PBS television star. And he was sharing a story about the music festival for Christmas in Kharkiv between the missile attacks. This is a lady who also had facial scars from shrapnel injuries, and what we did for her is we did a skin graft and lipofilling, and you can see this is 24 hours after her treatments, and you can see how her temporal area is now filled up, and her scars are much better, and she's smiling. And sometimes you just need to do a good blepharoplasty. And why do we go to a war zone? Well, to repair battle wounds, maybe. To repair emotional wounds, definitely. And for those of you who were there with us yesterday, this is Zlata, and she's a 9-year-old girl. And she presented to our clinic of 60 patients on a Sunday morning in Lviv, congenital patients at the Children's Hospital. We had 60 patients presenting for consultation that morning. And she showed up with her mom and dad. Well, where did they live? Well, they used to live in Mariupol. And if any of you know anything about Mariupol, it was the city that survived a month and a half of siege, and everybody left and evacuated. They've lost everything, and they live in a refugee camp north of Lviv. And she was there with mom and dad, and she was 9, and she was getting teased about her eye, much like our Ana Rosa, presented a great talk this morning on exactly this subject. And so Zlata was being teased, and the family wanted her to get fixed. And we said, okay, we'll put her on the list. And the parents said, could she be done today, please? Dad is a soldier on the front, and he has a leave, and we would like to be together for her surgery. So Jorge and I bumped her to the front of the list, and we took care of this young girl. And she obviously is smiling, and her family is very happy. So these procedures are often of the greatest benefit to the family and community, as much benefit to the family and community as to the individual. And every mission, all 5 missions, we have gone back to the Children's Hospital in Lviv. And this is one of I have a lot of pictures of me. This is one of my proudest pictures, I have to tell you. It has our mission statement on my scrubs. Underneath our transparent, if you will, scrub gowns. And there is the American flag next to the Ukrainian flag. And it's really been my honor to serve as an American boot on the ground supporting my Ukrainian colleagues. And Slava Ukraini, and thank you for this opportunity.
Thank you, Stuart. Like always, amazing presentation. Now we have the honor to speak Dr. Denisiuk Olga. This presentation that you'll hear is just absolutely amazing. And Olga has been along Oksana and the front lines from the very beginning about helping the Ukrainians and I think the rest of the world. So Olga, thank you.
Thank you very much for presenting me, Jorge. And I want to talk a little bit about how we live in Ukraine and what it's like to be a doctor in Ukraine. So we all know about the effects of war and how we go through war, but from blackouts to breakthroughs, it's sometimes just a single step. So what happens when you don't have any lights? Can you raise a hand who've been operating with no lights in there or are? Okay, few. We've talked with you. So what happens when you don't have any electricity, when you don't have water, when you get bombed almost every single day, and it's minus 25 outside and about Celsius and about +5 in the hospital, because there is no heating because Russia has shot everything down. So you can see this. These are not bad pictures. Those are pictures we're taking just a camera, because the only light that the generator would hold would we leave for the patients for the breathing machine, and this would be the surgical light that we would shine up into the room for us to see the instrument. This is not a bad picture of the instruments. This is how it is in my OR when we don't have any lights and it's winter and it's dark. So what we have, the problems, is high energy impact trauma, like Sue Stewart said, is like after radiation. So sometimes you do a perfect surgery and it doesn't survive. Delayed evacuation. What we have, we rarely, especially in Kyiv, we rarely get the fresh trauma because the patients are evacuated only by trains and by buses because we don't have any airplane connection. So it took me about 27 hours to get here from Kyiv to Ravello because we don't have any airplanes. So we had to take the train and then take the airplane. Sometimes limited imaging because at the front lines they don't have that availability because Russia bombs everything that comes in their way. So unfortunately, we do have some resources constrained which don't allow our surgeons to perform their best surgeries, but trust me, they do the best that they can in the circumstances that they have. This is a very, very emotional video for me. This is Children's Hospital in Ukraine, which was bombed by Russia. They said it's a military base and it should be destroyed. So they were shooting down a very civilian hospital. And a few hours later, you can see all of the citizens of Kyiv have come to help to clean the debris and get everything working again. Because these children, they're the oncology children, children on IVs, children that need constant life support. And when you say that, Russia might be thinking something, I don't think they do. Unfortunately, this is what they do. They terrorize and they destroy my country. This is a regular night in Ukraine. So you can see every single yellow line is a drone flying to Kyiv, flying to Lviv, Kharkiv, Dnipro, Ivano-Frankivsk, to all of the cities. This happens almost every night. A few days ago, Russia has bombed Kyiv and bombed Odessa and bombed Kharkiv and Dnipro, and we have over 25 people dead, including children, and over 100 people injured, including doctors and civilians who have been helping to clean everything up. But then, as you probably heard my confession yesterday, we wake up, we get dressed, and we go to the hospital. We have some doctors who've been shining their light on us. You can see here, on this picture, you can see Dr. Seif carrying a big black bag. This was on their first trip. It was a bag of goods, bag of orbital implants, of eye prosthetics, of silicone slings, of everything, and including sutures, because in the beginning we did have some problems with the logistics. You have here the next picture, Dr. Corona hugging our nurse. She doesn't speak a word in English, and he doesn't speak a word in Ukrainian. Well, now he does. He's really fluent. But they understood each other, and this was at the end the operating day, they understood each other perfectly. And you see we have patient-specific implants. We do have a manufacturer in Ukraine, but we also bring a company that helps our soldiers for free, just because they can. You can see Dave Russell, I see a huge team coming in, and it's going to be their 6th mission, right? 6th mission. This autumn, they're coming to help soldiers. And we have those patients who come in just to say hello, just to give a hug because they're happy and they know that they give the support. So the new reality of oculoplastics in Ukraine, orbital fractures, soft tissue loss, lacrimal destruction, combined trauma. We operate with max pace, with ENTs. We have an MDT team working together to restore our patients' faces. Because what happens is you can hide the scars behind your clothing, you can wear a prosthetic arm or a prosthetic leg, but you can't wear a prosthetic face. We have to restore the faces because they get scared, patients get agitated, they already have PTSD from serving at the front lines, but they also need someone to feel good about themselves while looking in the mirror. Of course, sometimes we have time pressure, we have a big physiological load. You can see these are not pictures from somewhere from the internet. These are the real pictures, what happens in Ukraine almost every single day or every single night. And they don't stop there. You can see here, this is me scrubbing in to the surgery with only my headlight on. And we can turn on the lights in the OR, but that would leave the generator work down. So I'd rather do some surgeries for the patient than turn on the lights. So imagine what it's like operating in pitch darkness with your phone sirens going on almost every single day. Of course, we do have patient-specific implants. We try to restore our patients as much as we can. And it's not that easy because patients get agitated, and sometimes reconstruction takes months, and usually it's years. So it's a long road, and our patients get tired, we get tired, but then we kind of have to keep on pushing each other. You can see here on the left side, this is a piece of drone that we took out of our patient's face. We are doing a lower lid reconstruction, and they said there's something on the CT that we kind of want to explore. So we explored. It was a piece of drone that was then sent for pathology, for diagnostics. This patient has lost one of his eye and lost 2 of his arms. He's very, very nice. He's super sweet, and he's fighting to survive right now. This is another patient of mine. I did a primary reconstruction on a so-called, as I say, fresh trauma, because there was an explosion and he fell down on the pavement and he had a little injury to his face. So this was primary reconstruction, and once it's done properly, the patient has a full restored function. He's very funny because he doesn't like the scar, and I keep on telling him this is the best thing that he can get. It might be better with time. So I want to share 2 cases, and these cases are very nice stories. So I do give nicknames to my patients. So this is a story about a patient that I called the RoboCop. It's not nice, but this man had a really, really horrible trauma, and you can see that his reconstruction was done to the edge of their possibilities, because they stitch it up, they stabilize, and then they try to evacuate as fast as they can. And we did actually several surgeries on this patient, and when he came in, you can see that he has a little hole and there's something moving in. So Dr. Saif said, this is going to take us about an hour, maybe an hour and a half. 6 hours later, we are in the surgery. We divide all of the sutures. We put the eyebrow from the nose back on the position. But if you see here, and as oculoplastic surgeons, we found the punctum. We were so excited that we found the punctum that Jorge was jumping in the OR. because finding the puncta means that there is an eyelid somewhere in there, and there it was. We started separating. When they say big skin grafts do not survive, they do if they put it properly. This patient was forbidden to smoke, not only by Dr. Saif, but by me and his wife. And he overcame few surgeries. And this is how his face was before the mission. This is when he came to the mission. And this is after surgeries we did. He was so happy. His wife sends me messages almost every 2 weeks saying that he's good. Finally, his grandchildren are not afraid of him because their grandchildren, well, I call him Robocop. What happened is that grandchildren end up calling him the Robocop too. So now he's not. Now he's grandfather, and he's smiling, and he's very, very happy with how he looks. And he doesn't even want to get any surgeries because he's happy. Another patient, which was a 2-year struggle, that by the end of our struggle, he really made me cry, and I'm not of the emotional people. So he lost his lower lid. He had a patient-specific implant on the orbital floor. He had very severe scar that was pulling the remnants of the lid down. And we did one surgery, and it didn't survive. We put in the amniotic membrane. We tried to reconstruct the lid without restoring any of the scar tissue. But it wasn't easy. So it was, all of the scars were pulling down. So we were doing massaging, we were doing PRP, we were doing steroids to inject to make the scars much, much softer. And the patient was really hard. He wasn't smiling, and he hated every needle. He hated every procedure. He was very hard, and he was very depressed because he couldn't wear the prosthetic eye. And he felt so uncomfortable and so bad about himself. Not only that he suffered the trauma, he has to see that trauma every single day. And he would always say that my injections are the most painful injections he'd ever have in his life. And it would be we would fight with him, and we would fight in a good way. And then he had his surgery. And this is why my talk came after Dr. Saif. I did the bucket handle, and we did it with one of our doctors, and I did it on my own. And you can see that the message he sent me, and this is the translation. So he was so happy for being there and for having, you see he's smiling. This is him after the surgery. And I want to take my time. Dr. Ramon Medel kind of stole my picture here because I sent it to him yesterday. So this is my first baby steps to oculoplastics with Daniel, with Luma, and I want to thank all of you for playing a part in me doing oculoplastics, because then I got to meet you guys, and then Jorge and Stuart came for the mission. And thank you very much for attention, and Slava Ukraini.
Outstanding presentation, Olga. Now we have Dr. Oksana Petrenko. Oksana is the president of the Ukrainian Society of Oculoplastic Surgeons and family to us.
Thank you, Jorge. I would like to sincerely thank the organized conference, Luigi and Jorge Corona, for the kind invitation and the incredible opportunity to speak in front of this audience. In 2020, an ASOEP was created in Ukraine. The Association of Specialists of Oculoplastic and Eye Prosthesis is to provide to essential medical care and reconstructive surgery to those who have endured severe facial trauma. With the onset of the full-scale invasion on February 24, 2022, the nature of ocular injury changed significantly. High-energy explosive injury resulted primarily from missile strike, bombing, mine explosion, and drone attacks. Exclusive injury mechanisms include primary action caused by blast wave, may result in globe rupture and internal ocular damage. Secondary action and direct injury from explosive fragment. Tertiary action, trauma from surrounding debris, including building materials and fortification fragment. And quaternary action, burn injury resulting from heat or chemical exposure. As a result, we have patients with severe eye injury, combined and multiple traumas, bilateral trauma, and orbital trauma. Most of the patients were male, age 18 to 78. Explosive injury made up 87% of causes, which is higher than gunshot or blunt trauma. And now you can see the faces of one, the young men who were injured while defending our country. Throughout our challenging journey of treating and rehabilitation patients with blast injury, we have received invaluable support from ophthalmologists around the world. We would like to express our sincere gratitude to our colleagues from Estonia, Artur Klet and Kadi Paloma, and to Professor Richard Allen for their support of Ukraine doctors and treatment of our military patients. We also acknowledge Dr. Vladimir Kratky for his repeated medical mission to Ukraine and his ongoing support. To Dr. Raymond Cho and his team for their medical mission to Ukraine and for sharing their experience. A special mention goes to the team of oculoplastic surgeons from the United States, led by Dr. Stuart Safe, thank you very much, and Jorge Corona, who visited Ukraine 6 times for medical mission, and during this mission, they examined and performed surgery on more than 200 patients. We work as a multidisciplinary team to provide the best care for the patient if the injury is severe, combined, and complex. Our team includes an ophthalmologist, maxillofacial surgeon, and ENT specialist. Now I would like to begin the presentation of the clinical cases as the result of our work. Here you can see a typical mind blast injury. 37-year-old patient with a mind blast injury sustained on July 2025. Right side anophthalmia, cicatricial deformities of the right lower eyelid, and fracture of the inferior, median, and lateral walls of the right orbit. As the first stage, we perform revision of the conjunctival cavity with placed in an intrascleral porous implant and reconstruction of the lower eyelid, and PSI was used for reconstruction of the orbit. But we observed a complication with the melting of the lower eyelid, and the patient required secondary reconstruction. As the second stage, we performed lower eyelid reconstruction using a huge tarsoconjunctival flap combined with a full-thickness skin graft. And here you can see the condition of the lower eyelid after reconstruction and CT scan after orbit reconstruction. Unfortunately, now in Ukraine we have many children with mind blast injury. This is a 12-year-old boy with a history of extensive burn injury involving the face and body. As a result, he developed significant cicatricial changes, including bilateral lower eyelid entropy and lagophthalmos. The surgical correction of the cicatricial lower eyelid ectropion includes the use of free skin graft from the supraclavicular area and the post-auricular area. The donor site for the full thickness skin graft was chosen based on limited available on intact tissue due to the burn injury. But here we can see the final result of the reconstruction. The next case in a 54-year-old patient with a mind blast injury sustained in June 2023. And this slide shows the patient's condition 2 months after primary surgery of debris on the periorbital region, and the patient history in mind blast injury and with left side anophthalmia and bilateral cicatricial atrophy of the lower eyelids. The patient underwent the following surgical treatment in right lower eyelid reconstruction with a full thickness skin graft from the supraclavicular area, and followed by right lower eyelid reconstruction using a transposition flap from the upper eyelid, revision of the left conjunctival cavity with placement on the intrascleral implant, and finally left lower eyelid reconstruction using a transposition flap from the upper eyelid. And the patient was referred to the ocularist for fabrication of the custom ocular prosthesis, and the patient looks like this. There are clinical cases that require the simultaneous presence of the specialist from different fields in the operating room, as in this case. In this case, an ENT specialist was required to close the defect resulting from the mind blast injury, and on this slide we can see the result of the reconstruction. But sometimes we have clinical cases when plastic surgery can't help. And in this situation, we need support our colleagues who made exoprosthesis for the patients, and then the patient look like this. Our multidisciplinary team helps patients who have been affected by the war. In our opinion, a multidisciplinary approach to patients with mind blast injury provides opportunities for high-tech reconstructive surgery and achieves the maximum functional and cosmetic results. Thank you very much.
Oksana, outstanding presentation. Thank you so much. And now we have Dr. Tofik. He is going to speak about eyelid and orbital injuries in Gaza and the West Bank. Thank you so much.
Good afternoon, and thank you for staying so late. And I'd like to thank the organizing committee for arranging this excellent session. I thought it's the first, but according to Dr. Saif, there is prior history of similar talks. So the disclosures first, the financial disclosure. I received royalties from WK Company for my book with Dr. John Dutton. However, it's so little because nobody buys books anymore, so please buy our book to make me more financially comfortable. But the more important disclosure here is what I refer to as the ancestral disclosure. I have to point out that my paternal grandmother from my father's side is actually Palestinian. She originated from northern Palestine, as the arrow shows. They were forced out of their homes in 1925, long before the Nakba, and they had to migrate to Egypt, where she met my grandfather. And in the slide in the lower right, unfortunately, they don't have a laser pointer. This is her in 1940 with my father with her native Palestinian dress. Despite this ancestral heritage, This talk has no political framing whatsoever. It's purely clinically grounded. The purpose initially was to retrospectively review the patients I saw after October 7th, 2023 from Gaza victims and discuss the epidemiological data, the management challenges, and the humanitarian considerations. However, I realized that I've always been seeing patients from Gaza and even the West Bank, and did not start in October 8th, 2023. So I decided to do a retrospective review of all my war victims in Gaza and the West Bank, which encompassed my extensive practice in Cairo from 1998. I only picked up in 2003, and my brief period in Amman, where I see more patients from the West Bank. So I was planning initially to divide these patients into patients with fractures, soft tissue trauma, anophthalmia, ocular injuries, and foreign bodies. And also, I was planning to segregate these patients into blast-related trauma, penetrating injuries, and patients who suffered blunt force trauma. I had a total of 76 patients, mainly from Cairo, only 4 patients from Amman, Jordan. And this number is impressive. Why? Because I'm not a referral person for patients from Gaza at all. Actually, where I work, very near to where I work, there is a hospital, Palestine hospital, which takes these patients, treats them for free. So I'm not a primary, secondary, or even a tertiary referral center for Gaza patients. I only see these patients accidentally, so I'm only seeing that these 76 patients are just the tip of the iceberg, and there are probably so much more. What I could say for certain is that injuries did not start on October 7th, October 8th, 2023, and they did not end in October 10th after the end of hostilities, after President Trump declared the end of hostilities. I've been seeing patients from 2003. Before that, my practice was very slow, so I didn't, probably this was going on since 1947. But I could segregate chronologically into 3 time frames the periorbital injuries. The first was the low-intensity conflicts between 2000 and 2023. I was seeing roughly a patient per year. And during the high-intensity period in 2023-2024, I've seen so few patients because it was very difficult to get to Egypt. And post-ceasefire, I was seeing a lot of patients, like 44 patients, and they were divided into 2 types. It's either the neglected cases from the war zone or the wartime in time frame 2, or post-ceasefire injuries, and they were not uncommon. The age ranged from 4 to 78 years old, mainly in young adults. This was the predominant. It's expected because they're in the streets all the time. But I had several patients above the age of 60 and few patients before the age of 12, but they're not the majority, contrary to what the media would tell you. Mainly they were males and not females. The more casualties were males. The most staggering result is that most patients, maybe I'm a tertiary referral person, but most patients presented with acquired anophthalmia. I had several patients with retained foreign bodies as well, and 3 patients had bilateral anophthalmia. Most patients had combined soft tissue injury and fracture, loss of the eye, and canalicular trauma and stuff like that. So rarely it was an isolated injury. Most patients had a blast-related trauma. I had claims of sniper injuries in 12 patients. However, I take these claims with a grain of salt. I only have 1 verified case of sniper injury. Maybe some of these patients are trying to attract sympathy. And I have an unusual case of blunt force trauma where the building literally fell on his head, and I'll show you the picture. So the conclusion is that anophthalmia represents a significant proportion of all combat injuries. We have a significant proportion of combined injuries, and blast-related mechanisms predominate. So representative cases, anophthalmia, this is an unfortunate gentleman with massive trauma and loss of both eyes. I'm not dealing with management here. Dr. Saif showed far better pictures, and the humanitarian perspective will be dealt with Dr. Ismaili. So another patient from 2014, by the way, these are not just from 2023. This guy is from 2014, he lost both eyes in conflict. And these patients, the one on the left lost her right eye, you can see there is also a canalicular trauma and 2025, but the central one and the one on the right are post ceasefire. They are from early 2026, and both declined rehabilitative surgery. And we had a lot of combined injuries. This guy with polytraumatized orbital contracted socket and loss of the eye, and this guy, who by the way was the national champion of gymnastics in Gaza, and he lost his left leg and his roof and his eye, and he was always asking, when can I get back to play gymnastics? A lot of foreign bodies. This unusual case, this was in 2018, again not pre-2023, and she was injured in some sort of blast. There was a campaign back then, and in Gaza they just removed the foreign body and transferred her to a hospital in Egypt. And there was, as Dr. Saif was saying, in emergency situations where you cannot always follow procedures, so there was no neurosurgeon, even a maxillofacial surgeon at presently. Only the hospital asked me just to switch her up and remove the eye, and then she vanished for they spent several weeks in the ICU, obviously, and then I received a text message on WhatsApp 1 year later from her son with her post-operative picture. Another child, this was 2006, with a bullet. Another child with a close-up gunshot injury from 2012. And this is the only verifiable case, I'm leaving this for last for a reason, of a sniper injury. This girl was leaving her home with her parents in Gaza, and she started crying and bleeding, and she got this bullet. However, I'd like to point out that her parents are not putting the blame on the IDF or the Israeli police. They don't know who shot her and why would her father was not politically engaged. And these type of .45 rifles are not used by the Israeli Defense Forces or not defending anyone here, I'm just stating scientific facts. They're only used by special forces in special Mossad forces. So why would they hit her? I don't know who did it. And fractures, I got a lot of fractures, combined rim fracture with loss of the eye. As I'm saying, these orbital ethmoidal fracture with loss of the eye. And then blunt force trauma, and this is the unusual case. This guy had literally the building fall over his head. So the roof fell over his head, and he was walking with 1/4 of his skull, and he's the funniest and nicest person to deal with. I tried reconstructing his socket, I failed miserably, and still he was very happy about it. He didn't give a shit. So it's just, this talk is not about, if I can give you allowed one final sentence, this is a message of peace. I'm not trying to attract sympathy with anyone. I'm hoping that by 2030, on the 9th ICOS meeting, there will be no more wars on earth and no more wars in our region. I dream of the Balfour Declaration too, which acknowledges the rights of everyone in the region, Arabs, Israelis, Muslims, Christians, and Jews, to live together under one flag, under one nation, and let's call it Israel time. No more wars, please. Thank you very much.
Thank you very much. Outstanding presentation. Now we have my dear friend, Dr. Bita Ismaili. She's going to speak about St. John's Hospital. Thank you so much.
Thank you very much, Hatem. I loved your talk. It's a very nice segue to this presentation. I have to acknowledge that I've never worked at a war zone, so this was really what I could come up with in response to Luigi's request to do something for the war zone. Do you know anyone who has actually served in Gaza? And as I think we're learning, there's restriction of movement, there's restriction of activity and involvement by not just Americans, but throughout the world. I think the war in Gaza has been very rapidly progressive and loss of human life, but also lack of access, relative lack of access. So I actually asked around from this organization that I have the honor of belonging to, the Order of St. John, which is a very long-standing eye hospital in Jerusalem, and I asked if they have any activity in the war zone, and the answer was this presentation, which is shared with me by Ahmed Mali, who's the CEO of the eye hospital in Jerusalem, and this will just summarize their activities during the last 2 years and some months since October 7th and since the intensifying war in Gaza. As you pointed out, perhaps that has been ongoing for many decades. Just a little bit of historical background. The Eye Hospital, the St. John Eye Hospital group in Jerusalem really has its history in the Middle Ages. During the Crusades, this hospital was first founded in the Middle Ages. You can see remnants of it today in the old city of Jerusalem and on Moristan Street. Moristan, interesting to me, I'm a Persian background, and Moristan is the local lingo way of saying Bimaristan, which is a Persian word for hospital. So the street is actually named after this hospital. If you go into the old city in Jerusalem and wander about, you'll see this remnant of the old hospital in front of a clinic that is now mostly symbolic. And then you can see how the building of the hospital over the years, and the modern day hospital is actually very much a state-of-the-art eye hospital that has treated many big-name Middle Eastern kings for their eye care. It's rooted in British system of teaching, has really deep ties with Moorfields Eye Hospital. And I have had the privilege of visiting several times, this most recently in 2022 with my son. It's a lovely place to visit. It's a very welcoming environment, and for anyone who wants to learn more about it, it's a good way to get involved with Israeli colleagues, but for Palestinian patient population for the most part. These are the mission and vision of the hospital. I am a member and I have no other disclosures. I actually donate. I am an officer of the Order of St. John for the U.S. Priory. But importantly, the St. John Eye Hospital Group is a center of excellence for providing ophthalmic care of high quality to all people of the Holy Land, irrespective of race, religion, and social class. And importantly, it has maintained very good relationship with the Israeli government. And I think this gives this hospital a unique opportunity to make a difference in the lives of all people in these territories. But of course, the Palestinian population is the vulnerable population that it tries to serve. And the standard hospitals are multiple sites. The hospital that I showed you, the main hospital, is in East Jerusalem. It's actually in a very lovely neighborhood if you go to visit. Historically, it's a very interesting place to visit. And then they have hospitals throughout the West Bank, Nablus Hospital, Kufar Akab Center, and then increasingly, and they had a hospital in Gaza, an eye hospital in Gaza, which has been damaged significantly. But as I will show you, these are slides given to me by the CEO, and these are their sort of the way they see this, their efforts moving forward is by taking services to the patients. So. Luigi asked me, do you know anybody who can tell us about the war in Gaza? Well, I really tried, but it's actually very difficult to get people that are actually providing eye care and providing trauma care in Gaza, because the hospitals have been destroyed. And the eye hospital in Gaza, the St. John Eye Hospital in Gaza, is not an exception. So there has been damage to the structure, as well as there is travel risk for the staff. There's travel risk for patients across the region, including West Bank, and there's overall reduced access. So I think the war has been going on for 30 months. I think we see this in the news, so there's none of this is news for us. This is the eye hospital in Gaza, and I think even prior to October 7th, there was sort of very, very difficult, although I have been to Jerusalem, to the East Jerusalem hospital many times, I had never made it to the Gaza hospital because, again, security is a real issue. Who gets to travel? which ophthalmologists get to travel to that hospital is really quite restrictive. So it's not just something that you can volunteer for an open door policy, as we saw with so many of our colleagues going to Ukraine, which is a privilege. That is not necessarily the case. It really wasn't even prior to October 7th, but it's increasingly more so today. So what the hospital has done is the strategy to bring services to the patients through vans that are traveling through tents and things like that. And here in this slide, Ahmed has tried to list for us the services, eye care services that they are trying to maintain. One of the most important ones is actually diabetic retinopathy care, because similar to some of the vulnerable populations in the United States, like the Native Americans, there is an epidemic of diabetic retinopathy amongst Palestinians, and I think that that's one of the main services that under these circumstances in Gaza they're trying to provide. They're trying to maintain diabetic retinopathy care despite the challenges, despite the ongoing challenges. And so in Gaza, they have treated over 100,000 patients during the conflict. And of course, again, this is an organization that very much prides itself in having the highest standard of care, including for their staff. So the welfare of their staff is a concern. So they have even some things that we don't think about, like maintaining their staff on salary payments when there's been very little activity at the main hospitals. By itself is a very costly endeavor, but they have been able to maintain that even for taking care of their own staff as vulnerable population during this time. And of course, the war has also affected individuals who live in the West Bank, restricted movement across that territory, and of course, the usual security concerns. So then this is Ahmad wanted me to share that this is our philosophy for the future. Hopefully this will bring some hope for the future. We're going to try to take eye care services to the population that need. And I have to say, for all the years that I've been a member of this order, we were always discouraged from offering our hands-on volunteerism as ophthalmologists, because the organization is not just limited to ophthalmologists, it's for anyone who wants to join. It's a charitable organization. But during this period, we are now told that, and the reason we were discouraged to do hands-on volunteerism is because it really is a hospital that has all levels of expertise, from specialty ophthalmologists to general ophthalmologists to ophthalmic, all kinds of ophthalmic care. But during this time, actually moving forward, they hope to get volunteers that will at least relieve the full-time staff because of the need that they foresee after the ceasefire holds. This is always always limitation. I'm not sure how it compares to Ukraine, as I learned a lot today that you are also working with constant violence, ongoing violence. But I think currently the situation in Gaza is still, it's a ceasefire, but it's still not quite a solid ceasefire. So I mentioned the main causes. Most of the causes of blindness amongst Palestinian population are preventable. Diabetic retinopathy is big, amblyopia is common, refractive error, and cataract. So they're really quite, it's really very similar to a lot of the other developing country environments that we are familiar with, the causes of blindness. These are the hopes of the hospital to be able to reactivate their vision screening programs for children, the neonatal eye screening. They were quite proud of that in Gaza before the recent conflict, and they hope to be able to reactivate that once the hospitals are safe to treat patients at. And again, diabetic retinopathy is really big, both in terms of screening and treatment. So, and then the goals, of course, the outreach program, as I mentioned. in refugee camps and otherwise. We're very proud of the Nablus Hospital. It's a brand new structure that was completely built based on a large donation from the United States, a member of the order, and this is now a running hospital. It has surgery suites. It has treated 16,000 patients just in 2025. This is in the West Bank. Kufar Akab Center is a little bit older, but it also has treated many patients and is beginning to provide more surgical care. And of course, our outreach program that I mentioned. These are traveling vans that travel to refugee camps and try to provide care during times of conflict. So again, Ahmed is kind of showing off our numbers. 231,000 patients have been treated in 2025 through these outreach programs, and over 4,000 major surgeries have been done. And of course, we are actually building a pharmacy, a commercial pharmacy in the West Bank, hoping that that will generate some revenue, much needed revenue for other components of the hospital. And there is also general anesthetic services being introduced in the Hebron Hospital, and solar panels, of course. So I included this last slide to say if any of you are interested in joining the order, we would be very pleased to entertain that. For Americans, there's a U.S. priority that, again, you don't have to be an ophthalmologist to be a member, but ophthalmologists are always welcome with open arms, and they advance through the ranks more quickly. This is an order of chivalry, so if you're into the English chivalrous orders, this is the real thing. Our most venerable order of the Hospital of St. John, and it was constituted in 1888 by Queen Victoria, and our sovereign head is King Charles himself. And membership brings with it many other benefits, including the social and friendships over the years. And also there's an ophthalmology association part of the order. So with that, I thank you for your attention, and I'm happy to entertain questions during the session later. Thank you.
Fratello, Luigi, grazie por la invitación. I want to really thank Luigi for allowing us to give us this space. Since Stuart and I have been involved with the war in Ukraine, and we have a part of our Ukrainian family here, this has been something really, really important to us. So thank you for giving us a space. I love this quote. Courage is not having the strength to go on. It is going on when you don't have the strength. I got these next quotes from Luigi's information that he has been giving us. In an area of AI, as you saw, my first image was AI generated, and virtual care, we reaffirm the essence of medicine. Listen, observe, touch, but I think most importantly, and care. So thank you for those words for this meeting, because I really think it's important to go back to basics. Olga just presented about a pediatric hospital being bombed in Kyiv. This is the image of the hospital, and that is the rocket hitting the hospital. Of course, the Russians said that there was like a military place there, and that the rocket actually was fired by their own Ukrainians. But they took pictures, and the Russian it was actually an Ukrainian rocket. We've seen these pictures throughout the day today, and most people cannot tolerate seeing these photos. We're all physicians here, so it's not that it's easier, but we at least understand that behind every one of these faces, there's human suffering. There's an emotional component that we don't see, and sometimes we cannot assess or gauge. We've been interviewed several times on different media, TV, in the United States or newspapers, but they don't want us to put any of the pictures because it's going to be bad for the people to see. But I think if people saw those pictures, definitely they will be less inclined to support or look at war in a different way. The picture of one of the patients, this picture, the one on your left, that picture, what actually, the patient had no legs, no arms, and the wife asked me to take the picture to please share it with the world of what was happening. Our team has been by including a lot of different people, so instead of like putting a few, I just wanted to put a picture of the whole team. But there are some that are very, very important, because this is a picture that was taken on the very first moment that Stuart and I arrived in the hospital on the first trip. We just met maybe 2 minutes before Olga and Oksana, that now are becoming part of our family. I want to say one more thing though. Oksana, when we met her a few years ago, her English was extremely, extremely limited. And now you hear her speaking perfect English, giving presentations around the world. This is another AI-generated image, but the pictures actually, the main pictures belong to me. This is my Apple Watch was about to run out of time, so we put another phone to show you that it was more than 17 hours since the time we left Warsaw to go to Kyiv on our last trip. And what you see on your right is actually a New Testament that is given to all the soldiers that go to war. And one of them gave me his, which is a very precious, precious thing for them. So when you arrive in Kyiv, it is incredible to see that the city, it keeps up and running. And here we have Marina, who's also here, preparing the patients that we are going to be working on during the trip. We have several meetings prior to going. It's extremely, extremely well organized. So it's incredible, actually, the resources and the level of expertise that they have. We really believe, Stuart and I, that this is a collaboration, because we didn't know what we were going to encounter. But like Olga told me once, well, we didn't know you were any good either. So it was a great thing for both of us to be learning from each other. In one of the trips that we went in October, only one day there were no drones. And we have an application on our phone that shows in real time where the Russian drones are coming. So that means that sometimes it's time to go to the shelter. As you can see, Stuart side going into the shelter. This is one of our patients, handsome young man. You can see he's with his military uniform, but he also has his lollipops there. Unfortunately, he sustained terrible injuries to his face. So why do we do reconstruction of the bones or reconstruction of the inside of the bodies when you would say, well, you're not going to see them, he's not going to see it? Well, two things. First of all, he will feel it, that there's something that is not complete. But the other thing is, like, for family, friends, and society, it's extremely important to rehabilitate the body even from inside, like a scaffold. So we are here examining our patient, and we determined that this patient could benefit from orbital implants. And we have a company in Dallas that they do patient-specific implants. So the Ukrainians send the images, we work with the engineers, and my wife, who has been to Ukraine twice with me, one time was watching this series, and I said, Jorge, you need to come, and can we see if we can put the sound on the next video, please? Can we add the sound to this video? Well, since it's not playing the sound, but essentially in this piece of the resident,
That's a chronic back, elbow, knee issue. Might not be a terminal disease, but you can feel it due to the impact it has on your life. But with 3D printing soon, we will be able to create patient-specific implants, customized, targeted, personal. This will be revolutionary.
well, it's not being in the future, it's already being performed as we speak. So here we are with Stuart analyzing where the PSIs will go. So we get these pieces are printed in Dallas, and at least in Dallas, one of these cases is about $20,000. The company has donated about $200,000 worth of equipment to Ukraine. So we are working here with the engineers, and I'm talking here to the engineers and saying, you know, the back is too long. You don't really have to cover all the way to the back. The patient doesn't have eyes, so they're like cutting the ear. So we're gonna cut it in the back. And then it's a very interesting process because this is in real time talking to them how we're gonna create the implants. They give us also these plastic models that they reconstruct, and we then take these and the models and all the equipment and we go to Ukraine. And the collaboration with the craniofacial surgeons, the neurosurgeons and everybody else, the plastic surgeons, is incredible because I have learned so much, including like, you know, the anatomy of areas.
You did a
We can stop the sound on this one. And, but here we are working, and you know, it's not normal that we do these very, very long incisions, but I have to say that it's interesting. I actually have now even cosmetic brows that sometimes they require like a huge elevation of the forehead, so now I do it with this approach. And here we are showing you the implant that we're about to place, and then we put the implant. And our patient, even though he sustained these injuries and he is still not completely rehabilitated, he comes to see us every time we come. Every 6 months he comes and he wants to spend time with us. And this person to the left of the patient, I thought initially was his wife, but it happens that she's a volunteer in Ukraine, that she takes all these soldiers to all the medical appointments, but you could tell how she senses that he needs the feeling of touch. So she's touching just his arm, and you can see that level of smile on his face. Now he actually does competitions of wall climbing, which is just absolutely amazing. And on this one, if we can actually restart the sound, please, that would be great. Thank you.
Which we operated together with Jorge in Kiev, and all on the team want to thank the company Medcat team for their support, help, and very nice products. Thank you very much.
И сказал все спасибо за операцию.
Nancy, we're so happy with all your help. Jonathan, to all the team, engineers, production, marketing, everyone. This is the first case we did here in Ukraine, and he's here to visit us. So far he's doing well, look at his smile, and it's an incredible accomplishment. And we brought more PSIs, patient-specific implants, so we're going to put them this week, working with Yuri, Sasha, and the rest of the team.
So here he is. Here is in the last visit in December of last year. Michelle is there with him. And I think this is something that is really important that Stuart told me. He has so many quotes, and I write them down, but this is one I like a lot. Giving them hope at time of hopelessness. And I have this picture at the beginning, the AI generated, but the picture where it was generated from is actually a picture that I took. And this picture you can just show, even without saying too many words, or no words at all, the despair that these patients have. So, brave like Ukraine, these are some of the socks that they wear. Hats off to all the Ukrainians, especially to all the women that once they leave the country, if they don't want, they don't have to, but they keep coming back. And one of the things that we, I think, have done, which is one of the things that we're more proud of, is to teach. And look, they're learning in very difficult circumstances. Look at Oksana now, she speaks English. This is Maria, she's now here with Stuart. If you're not willing to learn, no one can help you. If you are determined to learn, no one can stop you. This is yesterday, unfortunately, in Ukraine. 2 attacks, at least in 2 cities, there were more attacks. But switching now to where we are right now, just this beautiful, lovely place. And here I was remembering 10 years ago when I was walking in the streets in Italy with Daniel Weil. And I think his wife Eva is here with us. Eva, muchas gracias por estar aquí, porque me acordé muchísimo de Dani ayer que vi esta foto, que él me dice San Giorgio. So Dani used to call me San Giorgio, and I took this picture just here outside in this church. Here, this Dani and Luigi picked me up from the train station 10 years ago. And here is with my brother Jose Luis, my brother Luigi. But one thing I was thinking, you may wonder why I was coming with my bag. So Luigi, you need to come here. Jim Merritt and I thought that your t-shirt from the Cowboys was a little old and you needed a new one. So here you have your Cowboys hat, your Cowboys shirt. Thank you very much. Slava Ukraini. Was I the last one on the... Yep. Okay, so we have, I think, a few minutes for discussion, and we can open the mic. Anybody has questions? ¿Tiene preguntas? Again, I think it's a difficult topic, and I appreciate Luigi for giving us the time. Yes?
I'm not seeking attention, but each one of these presentations literally tears your heart. People selflessly sacrificing, putting them in the middle of crossfire, literally. I'm sorry to say this, it's not Ukraine, it's not Gaza, it's not Iran. Conflict zones happen everywhere. And unfortunately, everything that we are taught in residency and fellowship, lead lacerations, orbital fractures, none of that knowledge really is practically useful when you're in the middle of these conflicts. And I think that's where I think we as physicians have to come together as national societies, supranational societies. We have the American Society of Ophthalmic Trauma. I saw Oksana presenting the Society of Oculoplastics and Ophthalmia. We have the Asia Pacific Ophthalmic Trauma Society, where we need to have a pan-global ophthalmic trauma consortium, where we need to address damage control ophthalmology, which Bob Mazzoli pushes, right? Damage control. Doing trauma in the middle of where you don't have power, you don't have implants, you don't have technology. We need to create a new science, not only to repair it, but possibly even regulation to prevent these kind of maiming injuries. Because projectiles are being designed not just to kill, but maim these children and adults, regardless where in the world they are. I think that's where we need to come together. So thanks, Luigi, for really giving us an opportunity to put this session together. There you are. And I'm glad we're going to be addressing this, hopefully. We're going to have a session exclusively in WOC in Prague in a couple of months. And I think the whole world has to come together. Hope and pray to see you.
Thank you so much. Anybody else? Any other questions, comments? Again, Luigi, thank you so much.
Abbiamo la traduzione simultanea, però mi farà anche lui da traduttore simultaneo. Io sono onorato di avervi avuto qui, perché voi siete degli autori di queste opere enormi, dove il cuore va al di là della politica, al di là degli ideali, ma si va per il paziente. E per dare appunto un sorriso a chi l'ha perso. Bene, era proprio questo quello che volevamo fare con questa sessione di guerra, e tutti loro sono venuti qui pagandosi il volo, pagandosi l'hotel, pagando tutto. Loro hanno preso un treno di 12 ore per venire dall'Ucraina, per poter poi prendere il primo aereo, per poter raggiungerci a Napoli. Chi ha avuto ritardi aerei, però tutti sono venuti qui per dare questa dimostrazione, che è una dimostrazione di cuore. Grazie.
I was about to translate, but I think it was self-explanatory. Any other questions or comments? So what's next with you? We have a break or next session? So what's the next session?
Aesthetics.
Aesthetics. Okay, I think we're going to have a 15-minute break. Everybody can